So this gentleman's coming in because he had a fall, actually, tripped over some exercise equipment, so trying to stay healthy, so I give him credit. And he cracked his skull and he hurt his face through here. No loss of consciousness, no vomiting, no seizure activity, nothing like that. You can see this is gaping. So you can see that's right to the skull, that's there. These are the soft tissues that are there. It's torn a little bit, the skull's right there. Tissues are there. So what we have to do always is you want to reapproximate tissues. So this is why what you want to be doing, if you can see there, so if I tie it like that, see it's not approximating? You should be able to tell, this one has a little ridges, but you can tell that it fits right through there. Like that's where we want to be reattaching it. So essentially what I want to be doing, so they generally teach us that you want to be starting from one end of the laceration and then sort of extending the other direction. I find in these cases it's not quite as effective because I want to tack it down in the areas that I know the skin's going to come together better, and then I'll fill in the gaps afterwards. So we haven't frozen this yet, so we're going to have to use some, this is lidocaine, so I'm going to watch his eye here. Check from this part forward. You can feel a poke here, this will sting, I apologize. You okay? So people can ask why I bother asking if he's okay, because you're like, well, you're going to do it anyway. But if the patient's really uncomfortable, you can stop and give him a second to adjust. Sorry. Because this stuff does hurt. And this is why as well, when people talk about just adding extra, which we do obviously when it's necessary, but it's not done lightly because the freezing really does sting. I've had people who scream out, I've had people who pass out. You okay there? But if you're going to bother doing it, you do want to make sure the area is well anesthetized. This is not an infected field, so this should heal nicely for us. The problem in this particular case, we're doing this down in the clinic. Their instruments, I don't like them. They're a little bit dull. Won't be a problem for him. It's going to be a problem for me. But I mention it because I'll show people who are doing this. It's worth getting better equipment. Sorry. Yeah, it's a tough one. So the closer I get to his eye, the more uncomfortable he is. So in part of this will start to bleed more generally because it clots a little bit and then I'm opening that back up. Does that hurt when I do that?
No.
In this case, lidocaine, how long does it take to take effect, if you had to guess?
A minute?
Yeah, they generally stipulate 4 minutes as the absolute outside edge, but in most people it's almost instantaneous. So I'm going to clean this a little bit. So this is, again, teaching point. This seems obvious if you're watching this, but wait until it's actually frozen to do this. There's no point in scrubbing this down and making a mess of it when he's uncomfortable. So you might as well freeze all this because you have to anyway, and then you can scrub this and be a bit more aggressive with it and not hurt the patient. You okay there? Doesn't hurt too much?
No, I'm fine.
Now, if we thought that he cracked his skull, would we get a skull x-ray for this?
Not an X-ray.
No, why would we not do an x-ray?
X-ray might not even show us the fracture. We'll need to do a CT scan.
Yeah, that would be the debate. And what you debate with that is if the patient was clinically unstable, so if they were vomiting, if they were not themselves, they were falling all over the place. They don't get x-rays because those, even if you have a skull fracture, patients will heal nicely with that. It's only if there's actually
bleed with it.
yes, involvement of the brain, then we have trouble. So see what I'm doing here, this area here that you can see this pointed edge, this I want to be attaching first.
Right.
Because I want that anatomy to line back up.
Right.
Because I don't want to compromise his modeling career. Oh, I know it's extensive. I know. All that extra income. Now, essentially all I want to do is I want the skin to oppose. So the problem down here, what I'm using to actually put the needles, this is not technically even a needle driver, but this is just the equipment that they have down here. This will function okay, at least the teeth are still intact on this one. So here's another spot I want to be doing. And so why don't I bother cauterizing all of this? Like, why don't I try to cauterize this as it's trying to bleed?
It will heal very nicely on its own. We don't
Yeah.
want to disrupt the blood supply, which will help in the healing
Yeah.
process.
And in the long run, so when the reason why we have blood supply in the first place is to get clotting materials there, white cells there, all that type of stuff that'll help it heal in the long run. So this won't result in a hematoma because again, you have the underlying skull pushing back against it. You can actually put in a nice pressure dressing here. So you can see here's another area. So you can do this here. So yeah, so it may ooze a little bit, but if you're going to be the one doing these procedures, you just get used to what's excessive bleeding and what's normal. And if you can have normal bleeding, then you want to maintain that because that'll lead to a better healing result, so less scarring, because the blood supply is maintained and it can heal itself. If I'm cauterizing all of that, beyond it just not being necessary, I can actually make the end result less effective. So you can see how that's approximating, so it's coming back together like we want it to. So here are stitch-wise 3 loops. And here again, I'm not putting a lot of tension in here. I just want the membrane, the basement membranes to oppose. So you shouldn't have to pull a lot on these sutures. You just want it to be enough that the skin comes together, and that's about it. This isn't an area that'll be under, this isn't an area that'll be under a lot of tension. You're okay?
Mhm.
Now generally compared to other stitches I put in, do I think you put these closer or farther apart on the face? Closer, right? So they're going to be in for less time, so we want to seal this and then take these out so that we don't have any extra running marks from our actual stitch. So that when all that modeling money does come in, and he gives me 10% because do such a good job with this, that he has less marks on his face for sure. And I think people should always be aware of that regardless of what area we're dealing with, but specifically for the face, you better be consciously aware of it so we can minimize that as much as possible. Those stitches there somewhere. You're still feeling okay?
Yes.
is the only area I'm a little bit not worried about, but from a cosmetic perspective, I just want to keep an eye on. It's a little bit more ratty through here, so I want to make sure that that opposes well. This is where I talked before to you about just making sure that that membrane's opposing. So what I'm talking about, there's the basement membrane, so the sides of the skin are actually coming in contact, because if they're buckling, so if the one area is over top of the other, then he won't have as good a surgical result. And again, all kidding aside, I think we all, you know, this is hard to recover from, and you want as minimal scar as possible. I would want that. I'd want that for my kids. My family should be no different for this gentleman who's even trying to exercise regularly, so he gets a point in his favor. I was going to ask if you're ready for Christmas, but I know your wife's in the room, so I won't ask the question. I hope you're ready for Christmas.
Just ruined the pictures.
Oh, that's true. This is a very selfish fall, a very selfish injury. So what about from a concussion perspective? So if he was to go home and he vomited once, should he go to the hospital and get a CAT scan done?
Not for vomiting once, but if it's like continuous and
Yeah, and that's generally what we tell people. When you've had a significant trauma, like so a big bump, like he could go home and he may have enough that he feels nauseous and that he actually vomits once. But recurrent vomiting is an entirely different thing. So if he had one episode, I'd give him that. But beyond that, if that was happening, then I would certainly want him to go to the hospital and we'd have to get a CAT scan done. Just one more here. So if this was less jagged, and if it was more horizontal than vertical, he's kind of got a combination of planes going on here, so it's shifting on him. What we could have debated doing is whether we could tack that down in those, 3-4 spots, and then just steri strip the rest. Because again, there's not going to be a lot of pressure here, and we can do that, and we have less scarring potential. You're always weighing in a balance of strength of the actual incision that you're repairing versus cosmetic result. But the problem in this particular case, it's running in different directions, which will put more pressure on it. It's also going through the the hair of the eyebrow. So how well that would tape down would be the issue for us.
yeah. What about the ones on his lower lid? Are they
Those ones are not
superficial?
gaping. Yeah, they're superficial, so those should heal nicely for him. So essentially what I want to assess now is I'm going through to sort of see, is this well opposed consistently? Do I think the basement membranes are lying nicely against each other? So this next one, see this area is a little bit up, not too bad. That's here, which is a little bit more ratty through here, but not too bad. That area looks pretty good. So essentially what I do now is I'm going to moisturize this fairly well. We'll put a dressing on that. I do like using, La Roche-Posay has a cream called Cicaplast that I like. It helps minimize scarring. I like particularly using it sometimes around day 3, day 4, and then these stitches will come out around day 5. So we're going to clean up the rest of things, get the stitches all in place, and then we'll go from there. So this is follow-up from the eye laceration, so you can sort of see that it's approximated quite well. The nice thing with this is it's regressed a bit to the eyebrow border, so that line that's a little bit thicker, which is through here, that's probably going to fade even more, so that'll look good over the course of the next little while.